A 65-year-old man with syncope, dyspnea, and leg edema. Syncope is defined as a transient self-limit loss of consciousness with an inability to maintain postural tone that is followed by spontaneous recovery. Dyspnea refers to a sensation of difficult or uncomfortable breathing. The patient had been in his usual health until approximately 1 month before admission, when cause occurred. 1 week later, his legs became swollen and weeping sores developed. Dyspnea on exertion with orthopnea developed and was associated with a weight gain of 6 kg. The patient was seen with his primary care physician at another hospital.
Time start now? Alright, so in 3 minutes, I hope that I can summarize what we do and keep your interest a little bit. So, in my lab specifically, I study the symptom of dyspnea. So for those of you who are not familiar with that, it's another more technical term for breathlessness or shortness of breath. And really, the technical definition is that it's a subjective experience of breathing discomfort that people commonly will experience during physical activities such as exercise. So we're all common, or we're all familiar with this type of sensation. What's important is that this symptom is actually a common and very debilitating symptom in patients with chronic heart or lung disease, and particularly in the context of exercise. So you have individuals who smoke for a long period of time, and they develop emphysema or bronchitis, and they become extremely uncomfortable. It limits their activities of daily living, and really leads to an impoverished health-related quality of life. So here I have a gentleman with COPD, and on the right side there you see reasons for stopping exercise. So we bring a large number of individuals into the laboratory, we put them on a bicycle, we ask them to exercise as long and as hard as they can, and when they're completely at their point of exhaustion, we say, why did you stop exercise? Your breathing discomfort, your leg discomfort, a combination of the two, or something else. And you can see that as many as 63% of these people complain of shortness of breath as the primary reason for them stopping exercise. So that anchors it from a clinical perspective that this is a very important symptom to understand so that we can effectively manage it and treat it. So a brief neurophysiology of this symptom. In the most basic sense, breathlessness really reflects the relationship of the drive to breathe and how well our respiratory system is able to accommodate this drive. So when healthy individuals, like presumably everybody in the room, you start exercising on a bicycle in the laboratory, we have increases in the drive to breathe and an appropriate response to the respiratory system in terms of how much volume we breathe, how quickly we breathe, and so on and so forth. And under these conditions, we get a normal awareness of an increase of our breathing. It may or may not be inherently uncomfortable, but we definitely notice our breathing. However, you take an individual who, say, has developed through bad habits, emphysema or bronchitis, And what happens is that they have a very accelerated drive to breathe. So there's a lot of drive going from the brain to the respiratory muscles, but because of the thickness of their lungs and their airways, they can't essentially do the work that's necessary to match it. And under these circumstances, people become incredibly symptomatic and incredibly short of breath, and they're limited in their exercise at levels of intensity that we take for granted walking upstairs. So in our lab, we use exercise on the bicycle as a stress. We measure the physiological responses using a metabolic cart, as you see there in the second white picture. We're unique in that we have about a meter-long catheter that we push through the nose, down to the stomach and the esophagus, which measures how well the respiratory system is actually responding to stress. And there's one of my undergraduate research students who's actually performing a technique or procedure with the catheter actually pushed, and it's down about 55 centimeters into his body. When we record these measurements, we actually do recordings of the electrical activity of the diaphragm. So I'll show you 5 channels here, and the esophagus and stomach, and the pressure in the esophagus, the gastric pressure, and how much air is moving into and out of the lungs. And so you can see that an individual at rest, you can see that the brain is really not sending all that much information on a per breath basis, a little bit of pressure being generated and a little bit of flow. But as we move into moderate and more strenuous exercise, you can see that the activation of the breathing muscle grows, the muscles begin to do more work, and particularly near strenuous exercise. So we can see how appropriate these responses are. Once we've quantified these things, we can relate our sensation, different physiological responses, and compare these responses across individuals or across groups. So, I know I'm over my time, but just to give you a sense of how we're applying these techniques, we're currently doing studies looking at patients with COPD. We're mimicking disease by essentially restricting the thorax using a chest wall strap. We're binding the abdomen with to essentially increase the pressures in there. We're doing studies related to obesity, and we're comparing responses between healthy young men and women.
It's important to identify the price cost of syncope because the prognosis for patients with syncope depends on the underlying disease. Since mortality is worse among patients who have syncope caused by structural heart disease or a cardiovascular entity, one it is critically important to consider cardiac causes.
This is a brief video on valvular diseases of the left heart. We're going to be going through aortic valve stenosis, aortic valve regurgitation, mitral valve stenosis, and mitral valve regurgitation. Now, it's worth noting that sometimes the regurgitation diseases are also called insufficiency. So we'll be talking about aortic valve insufficiency, which is the same as aortic regurgitation. Before we begin, we have 2 pathology pictures here. The left one is an aortic valve stenosis, and the right one is a mitral valve stenosis. Now let's jump right into them. Let's start with the aortic valve stenosis. Aortic valve stenosis is defined as the failure of the aortic valve to open. This happens during systole when the ventricles contract. The etiology comes from 3 main causes. The most common is the last one listed there, age-related calcification. Now, this happens through a mechanism similar to coronary atherosclerosis, so the same risk factors apply, and that's like diabetes, that's hyperlipidemia, high cholesterol, it's also obesity doesn't help, smoking doesn't help. One less common cause is rheumatic fever, and even less common than that is a congenital defect, such as a bicuspid aortic valve, which is when the aortic valve is made with 2 leaflets instead of 3. Demographic for aortic valve stenosis is usually older people, usually males, again, very similar to coronary atherosclerosis. On the physical exam, we hear a murmur. This is a crescendo-decrescendo murmur. This means that it increases in intensity and then decreases in intensity. And it's worth noting that the point of maximum intensity in murmurs that correspond to worse disease peak later. So we see diastole, as you can see in that D line of that picture there. You do see a wide pulse pressure. This means that we have a lower diastolic pressure and a higher systolic pressure. So there's a wider pulse pressure. Diastolic pressure decreases because our left ventricle dilates with volume overload, and the left ventricle compliance thus increases. And again, we see a systolic increase because we have more volume with each beat. We have two sources of blood coming to the left ventricles. This is usually caused by rheumatic fever. It can also be congenital. Infective endocarditis can cause this, and again, calcific disease can cause this as well. Physical exam, we do hear a murmur here. There's an opening snap. That's a noise you hear of the mitral valve snapping open, especially if it's calcific, it can make a pretty loud noise. We do have a diastolic coughing up blood. And of course, right heart failure shows the same typical symptoms. We have increased JVP, high pressure, sometimes seen in the neck. We can also have leg edema, swelling of the legs. We have ascites, swelling of the abdomen. And for this is diuretics, both pulmonary and systemic. During systole, which is when the mitral valves should be closed. When they're failing to close is when we hear the murmur. This is a hollow systolic, high-pitched murmur. Hollow systolic means that it's the same intensity throughout all of systole. It's heard best at the apex. You might hear growls in the lungs, again corresponding to pulmonary edema. ECG shows acute infero-posterior myocardial infarction if the papillary muscle is ruptured.
A 65-year-old man present with syncope 1 month earlier called dyspnea and leg edema had developed. Imaging studies of the chest revealed lymphadenopathy. An echocardiogram showed hypertrophic obstructive cardiomyopathy.
Dyspnea is shortness of breath. It's a very common symptom in a lot of illnesses and conditions. People think of COPD or interstitial lung disease or pulmonary hypertension, but it can also go along with conditions like heart failure and cancers, and really there can be so much suffering that goes along with the shortness of breath. It causes anxiety and depression and dependence on others for help around the house and doing errands, and it just can make people feel so terrible. What amazes me about a lot of patients I meet with advanced lung disease is how accustomed many of them become to the limitations of their breathing. Some of them become very used to walking 10 feet and stopping and resting, and they at least tell me sometimes that it doesn't bother them, and some people it does bother. So really it's taking a very personal, very patient-focused approach to how does it affect them, and how do we help make it better.
So now let's talk a little bit about this shortness of breath. It's called dyspnea because it comes about when patients do things. Doctors call it dyspnea. They grade it from 1 to 4, so they talk about dyspnea, grade 1, grade 2, and grade 3, and they give patients various tasks. Can you walk 5 yards or so? Can you go up and down the stairs? Can you do so and so and so and so and so and so? So the next time they can see you, they'll know whether you're more dyspneic or whether you've made progress. Another thing which happens with patients that have left ventricular failure, congestive heart failure, is that they complain of shortness of breath, not when they're walking, not when they're going up and down the stairs, but at night. So it wakes them out of their slumber. Then that is called paroxysmal nocturnal dyspnea. It's called paroxysmal because it occurs in attacks, nocturnal because it happens at night time, and dyspnea because that's what it is, shortness of breath. I mean, patients will not come up and say to you, last night I had paroxysmal nocturnal dyspnea. But they will come up and say, my wife made me a lovely meal last night, and I was doing perfectly well for myself. I went up and down the stairs, I took my clothes off, I was perhaps just a little bit short of breath taking my clothes off, and I went to bed, I read my book, and I fell asleep. And I woke up at 3 a.m., desperately short of breath, gasping for air. I had to sit up. It was very unpleasant, very uncomfortable. And sometimes that is called cardiac asthma or paroxysmal nocturnal dyspnea. And there are various reasons for this. I need not bother telling you all about this. I'll suffice it to say that if you lie someone flat in bed, you compromise the failing heart method. And that's what normally people do when they go to bed. They lie flat in bed. And when you lie someone flat in bed, you increase the inflow of blood to the right side, and you decrease the pulmonary venous drainage on the left. And the lungs become squeezed in the middle. And you end up with cardiac asthma.
The patient has done well after cardiac surgery. He is being monitored in both the sarcoid clinic and the hypertrophic cardiomyopathy clinic at this hospital. The final diagnosis is sarcoidosis involving the heart, thoracic, and inguinal lymph nodes.
Sarcoidosis is it's an unusual disease where the lymph nodes get inflamed in the chest, and it can involve other organs, but it's a benign condition, a very good prognosis, very treatable. Because it's a fairly uncommon disease, we have established a dedicated clinic to take care of patients with sarcoidosis at the university. Sarcoidosis occurs about 50% in the Caucasian population and 50% in the African American population. The peak age is around age 40, so it's sort of a young to middle-age disease. Sarcoidosis, again, in most people is totally asymptomatic. In those who are symptomatic, it's about a year-long illness, and then it goes away. Now, they may still have the swollen lymph nodes, but the sarcoid is inactive, and they never have another problem. It's about 5% of sarcoidosis patients have chronic disease with relapses and flares and need chronic therapy. Probably the most common symptom in sarcoidosis is cough and maybe some shortness of breath, and then usually a chest x-ray is obtained and they see the swollen lymph nodes. Other symptoms would be joint complaints and a skin rash, and people can be fairly ill with fever and night sweats and weight loss, or they can present more chronically with cough and shortness of breath. The treatment of sarcoidosis, it's interesting, it runs the gamut. About 75% of people never know they had the disease. They get a chest x-ray for surgery or something else, and they see these big swollen lymph nodes. So 75% don't need treatment at all. 25% do have a symptom, do need treatment, and the treatment is largely with corticosteroids, which are very effective, but because sometimes treatment needs to go on for 6 to 12 months or even longer, we have investigated other options to try and avoid the corticosteroid side effects, so things like methotrexate and Imuran, and even some of the drugs that are used in rheumatoid arthritis, like Remicade, are used in sarcoidosis.